Hello, my name is Peter Schneider. I'm a vascular surgeon from San Francisco, and I'm here with an esteemed panel of experts on asymptomatic carotid stenosis. As you know, this is a pivotal moment for carotid disease treatment as the CREST-2 trial will shortly be revealed. I'm here with, as I said, a panel of experts, which includes Rick Powell, a quite experienced vascular surgeon from Dartmouth, Dr. Ann Abbott, neurologist from Melbourne, Australia, and also Dr. Tom Brott, one of the PIs and original designers of the CREST-2 trial, who is a neurologist at the Mayo Clinic in Florida. So in the few minutes that we have, like I said, it's a pivotal time. I'd love to hear from this panel of experts the kinds of things that the clinicians out there who are interested in this subject and who are treating these patients would like to know. So, Tom, this has been quite a journey for you. Maybe you could just tell a little bit about the story of how CREST-2 came about, why you thought it was so important, and what your anticipation is for, obviously, the next 2 days, which is going to be a big, big deal for our field.
Well, it is a saga which, in terms of randomized clinical trials, began in the United States with the ACAS trial, which was published in 1995. And then the ACST trial, published out of the UK and Europe in 2004. But basically, since those randomized trials, we haven't had comparisons of surgery, which worked in those trials, to medical care without surgery. And it's important to look at the latter, the medical therapy, because of improvements, a lot of them in medical therapy, not only the improvements in medical therapy, but the cessation of smoking, where it used to be almost half of the patients in the United States, and now it's down toward 15%. So we've got today, compared to a generation ago, we have rightly questioning the value of these interventional procedures. The second part of the saga was the new kid on the block, carotid artery stenting. Trials in the 2000s, published in 2008, 2010, showed that with carotid stenting, there may be a greater risk for procedural stroke, usually small, than carotid surgery, but also some evidence to indicate that overall they're very equivalent. And then another study, ACST2, really validated the CREST trial, showing these two procedural treatments, carotid surgery and carotid stenting. So the big question is medicine alone good enough?
Right. Yeah, that's a great juncture. Maybe we could hear from Dr. Abbott. You've been a long-term proponent of the value of medical management in these patients. And I'm wondering if you could just tell us, what do you think with the medical management arm, if you were to predict, we won't have to wait too long to find out, but if you were to predict, do you think that the medical management that was administered in the trial will be successful? And do you think it's reproducible in the real world, the type of medical management that was used in the CREST-2 trial?
Well, the medical management as outlined in publications so far is pretty reasonable, and you could argue could even be more intense. And it's all possible, but it does require a good knowledge of how to define risk factors. Definitions have changed over the years, become more sensitive, and searching for them all and managing them with lifestyle interventions, so diet, exercise, other lifestyle factors and medication. So there's a lot of knowledge required, but it's all possible, and it does involve regular follow-up patients to address new risk factors, problems with medications, and all sorts of things. But with that sort of management, we can reduce the risk of stroke in people with asymptomatic carotid stenosis by at least 70% compared to how things were in the 1980s and 1990s when ACAS was done. Now, with the CREST-2 results, I'm anticipating that we'll see an average annual ipsilateral stroke rate in medically treated people of less than 1%, because we've already had some reliable measurements in recent years. They're about 0.7%, so I'm expecting about that for CREST-2. And with that risk, with non-invasive arterial care alone, you're not going to see a net procedural benefit for the type of people that went into CREST-2 or ACAS for that matter. The question is whether there'll be a subgroup that benefits from a procedure. And if there is a benefit, it's going to be endarterectomy, not stenting, because clearly stenting does cause more peri-procedural stroke, death, and heart attack than endarterectomy. But I don't think CREST-2 was really powered enough to look at subgroups. So I think it's going to show really no procedural benefit with respect to patients with asymptomatic carotid stenosis overall. And with that result, that should stop us doing endarterectomy and stenting, because there's clearly no evidence of benefit now from these procedures for asymptomatic carotid stenosis, only risk of stroke, death, and of course the huge costs involved. So we should be turning our attention now to symptomatic people, because the same situation applies, that we just haven't measured their outcomes with non-invasive care alone since about 40 years ago, when a couple of randomized trials were done. And if we're going to have procedural benefit for anyone, it's going to be subgroups, and very selected subgroups of symptomatic patients.
And Dr. Powell, you're an experienced carotid surgeon. Also, you do interventions, TCAR, transfemoral, CEA, and you also enrolled in the CREST-2 trial. So one of the issues that typically comes up with a randomized controlled trial is how generalizable is it to the population at large? And as an enroller in the trial, what was your experience? Do you think this will be generalizable to the broader population, or will this be not quite so clear? Or what do you think about that?
Yeah, thanks, Peter. We enrolled in CREST-1, and that was a relatively easy trial to enroll patients into, because the patients were going to get what they felt was some sort of treatment. And when we enrolled in CREST-2, the patients would come in, it would be very polarized. They'd be told things by their referring physician. You're a time bomb, you're going to have a stroke any second. And so it was really difficult to then sort of, level set the patient, reset their expectations, and then get them to try to enroll in a trial where, in their mind, they were receiving, usual care versus a procedure that was needed to be done to, quote unquote, prevent them from having a stroke any second. And I think, that right there, my hat's off to Dr. Brott and his team for the ability to actually complete this trial, because of, it was not easy to enroll into this trial. And as far as the results, it'll be, we all have our biases. By tomorrow afternoon, I think we'll have a good idea as to, what the best way to treat these patients are. It'll be another step forward. And, I'm as eager as anyone to find out, what the results look like in order to be able to treat my patients with the best therapy possible.
Yeah,
so I look
good.
forward to it.
Yeah, thanks, Rick. And back to Dr. Brott. What do you think, Tom, will be the biggest criticisms of the trial? Whenever we have a trial, there's always the story of the trial, and then there's the story of where could it be better, where was it fantastic. What do you think you'll be talking about in the days after the trial about, what are the weakest points or criticisms that people will make, and what are the strongest points? I mean, Rick already mentioned some of the strongest. I mean, this is a real tour de force. So what do you think?
Well, I think the critique that Richard just made with regard to the difficulties in enrollment and the baggage that patients brought to their surgeons, their interventionists, their internists, did make it difficult to enroll. And so the enrollment period was about 10 years. And we wish that it would have been as quick as it was for CREST-2. So I think that is a reasonable criticism. I would say that we were forced in the course of publication to compare our population to other population-based assessments of this group, and it turned out to be pretty representative. The second thing would be that the way we ascertain stroke makes comparisons different compared to ACAS and ACST. So, for instance, if you any of us go into a hospital in New York City today, and we have temporary weakness that may last 1 or 2 hours or 6 hours, you'll get an MRI scan. And if the MRI scan shows a defect on DWI, diffusion-weighted imaging, it will be called a stroke. And so the goalposts have changed a little bit in terms of what we call a stroke. So it makes comparisons difficult. As far as the real-world medicine is concerned, since we began the trial, control of blood pressure, control of lipids in our culture has become widespread. You can't watch television today without seeing ads for lipid-lowering drugs, better control of diabetes, ways to quit smoking. And so the critique that the medical care was not realistic was true perhaps very early on, but hasn't been true for at least the last 5 or 6 years.
That may well be, as you say, one of those things that has clearly evolved over these 10 years during the enrollment. One of the things I'm wondering about is obviously the comparator is medical management, and you were very eloquent about that. There's been a lot published about that, what the medical management goals are, et cetera. And but it also included the lifestyle intervention company, Intervent. And I'm wondering, when the trial is over, will the medically managed patients continue to be coached by the lifestyle intervention company, or is it felt to be not necessary because now the patients really understand better how to be compliant with their medications and how to be appropriately followed or be under surveillance? What do you think about that?
Well, I think that we didn't continue Intervent for the patients beyond a couple of years, but it was very educational, and that education, of course, stuck. And then if you watch television, if you stream, you're being bombarded these days about what you should do in terms of exercise, lipids, blood pressure, all the risk factors, which I think helps. It won't substitute for the Intervent calls, the counseling, but certainly I think it will help.
That makes a lot of sense. Well, I think we have a lot to look forward to in the next couple of days. The results will be shown in a session on Friday afternoon at the VEITH meeting, and we'll have some discussion afterward, which I think will be very exciting. I think the entire world of people that care for patients with carotid disease will hear about this. Their practices will be affected by it, and we'll see how it goes. Rick Powell, any closing statement?
No, I'm excited to see the results of that Tom's going to bring to us tomorrow, and I think it'll be a lot easier with some data in hand if it turns out that patients do not need carotid disease to be intervened on, that we have some data to actually show them that is level 1A data.
Yeah. And Abbott, closing statement?
Oh, it's going to be, will also require some time to look at these results, because I can already hear warnings that the headlines are not going to be enough. Definition of stroke, critical. You've got to compare apples with apples. So it sounds like their primary outcome measure might be more like stroke and TIA, which will overinflate numbers with medical care alone. So we'll have to look at the paper and take some time to really sort out what's happened.
Very good. Tom Brott, are you going to take a day off after this? Or?
No, I think all of us agree, rigorous information about carotid disease, symptomatic and asymptomatic, is a good thing.
Very good. Well, I'd like to thank the panelists, Dr. Powell, Dr. Abbott, Dr. Brott, for their keen insights, and we'll look forward to the next few days and the next steps. Thank you.
Thank you,
Peter.